Assalamu alaikum, the communication day. First scenario, Mr. Ahmed is 70 years old, admitted with pneumonia and type 2 respiratory failure with rising CO2, and he's drowsy. Please sit with him as he's refusing to be connected to non-invasive or BiPAP machine. Your task as a medical registrar to speak with Mr. Ahmed, address the concern and assess the capacity. Ready, Dr. Ayola?
Yes, please.
Okay, here you go.
Yeah, hello.
Hello, doctor.
Yeah, my name is Dr. Wayola. I'm one of the doctors that is looking after you. Okay, can I confirm I'm speaking with Mr. Med, 70 years?
Yes, I am.
Okay. And how do you feel today?
I am really not comfortable, and I am, as you see, getting this crazy thoughts in this hospital.
Oh,
I am about to go home. I need to go home. I am pretty okay, actually.
Oh, I'd see, Mr. Med. And well, that is one of the reasons I'm here to have a conversation with you about an update about your health. Okay? But before we start, before I dash into what I want to discuss today, can I check your understanding about what you understand about what has been going on since you've been with us?
I received some antibiotics, I remember, and I want to go home.
Yeah. Okay, Mr. Med. I understand you want to go home, and thank you for sharing that with me. Is there any particular reason why you want to go home?
Because I am fine.
Okay, I'd say all right. Well, I'll just put you through. Discuss with you where we are in your health and what we found, and what we think might be beneficial to you at this point. Is this something that you want me to discuss right now?
What is beneficial for me is if I go home, doctor.
Okay. I see that.
Really?
Okay, I see, Mr. Med, that you really want to go home. But if you permit me to discuss what, in terms of your health, where we are, in terms of your diagnosis and what we plan to do for you, then we can discuss and see if really going home will be the best option at this time. Is that okay?
Okay.
All right. So, Mr. Med, you came in with some symptoms, and we've been found that you have what we call pneumonia, which is basically a chest infection. Okay? And since you've been with us, we've been assessing you and been monitoring you closely. This chest infection that you have, unfortunately, is quite a bad one, Mr. Ahmed. And it has affected your breathing, the function of your lungs, and is gradually reducing the way your body handles oxygen, which is important for our breathing. This is going down.
I want to go home.
At sea, Mr. Ahmed. But I understand that you want to go home, but at this point, we don't think it's the best option. We don't think it's something that would be in your best interest at this time, because you are in what we call respiratory failure. Do you know what that means, Mr. Ahmed?
Doctor, why you are like so resistant to me?
Oh, Mr. Ahmed, I'm so sorry if I make you feel that way. But I'm not, it's not that I don't want I don't want you to feel as if I'm resistant to you. I just thought to let you know that at this point, your breathing is not quite good. And you would need support in terms of your breathing to help with your breathing. And if we don't do this, there are chances that your respiration, your breathing capacity will continue to drop.
What is this? What is this you want to do?
And what I want to do is to connect you to a machine that will help with your breathing. We will put a mask on your face and connect to a machine which will give you oxygen and also take out the waste products that might be that may be harmful to your body, which the lungs will normally handle. But because of your condition, the lungs is not handling this. So it is building up in your body. So when we connect you to them, and this would affect affect the way your concentration. It will make you tired. Your breathing will continue to get worsened. Our aim is to help you with this machine, putting a mask on your face, connect to the machine, which will take out this waste product and give you oxygen, which will help you overall health. And this is in your best interest. What do you think, Mr. Ahmed?
I don't know. I want to go home.
Okay. But if I know that it's like I know I asked earlier, apart from feeling that you are well, is there any particular reason why you want to go home?
I don't know. Doctor, I feel I will be better when I go home.
Or yeah, I quite appreciate you sharing this with me. But from all indication and all that we've examined, we've seen type 2 respiration, the respiratory failure, that you have is not something that could be managed at home. You need oxygen support, and this needs to be done as inpatient while you are with us in the hospital. Okay?
Mm, mm,
Do you quite understand what I've
mm,
said thus far, Mr. Ahmed?
mm,
Do you follow me?
I don't know. I just want home.
Well, if you want to go home,
Why you are here, doctor?
I'm here to discuss this, what we plan to do for you. But if you want to go home, may I just ask you, do you understand what I've said thus far?
Can I do anything? Can I do anything? Just I will walk away now. I need somebody to help me with that.
Okay, yeah, it's fine. We can, if you want to go home, we can look at things that we can do. But before then, I just want to know if you quite understand what I've said to you. Could you tell me, if you don't mind, could you tell me what we've discussed so far in terms of your health and what we plan to do for you?
You spoke that I'm in a not good thing. I will be very sick.
And
Yeah.
also that we need to give you oxygen because this will help with your breathing and help you out of the way you feel right now.
But I don't want anything. I want to go home.
Okay, if you want to go home, we can support you as much as you can. You have the decision to make.
2 minutes left.
I just suggest that you carry on with this, and if you face any trouble during this, we'll be able to support you, possibly adjusting the mask. Even if there's anything whatsoever that troubles you about this procedure, is there any reason why you don't want this procedure, if I may ask, Mr. Ahmed?
I don't like any mask.
Okay, hard to see. Okay. And what if we look at things we can do, like giving you the mask intermittently? Take it off sometimes, put it on you sometimes, just to help you with this. What do you think?
No, not still. I'm not I want to go home.
Okay, if you want to go home, we can look at things that we can do. I will inform my seniors about this, the consultants about this, and then I would try to see if we can get him. I will try to get him to talk to you, but possibly explain more about this. But if you still want to go home, then we would support you as much as possible. But there is a form that you need to find about this. But a form that you need to
Can I
sign.
sign this form now?
Yeah, but before we do that, I would want my seniors to have a conversation with you about this, okay? And then we can discuss further. Is that all right? Do you have any family member that you think you can have this conversation with? Any support that you think we can discuss this and
Yeah,
that
speak
you
with
can
my
discuss?
son.
Okay, all right. So we'll have a conversation with your son since you've given us the go ahead to do that, and then we would see ways to go about this. Okay.
Okay.
All right. Do you have any question for me at this point?
No.
Okay, but in the meantime, I would want you to think about this, okay? And then we could give you some
Huh.
oxygen in the with some prom in your nose for the meantime while you are with us, okay? I will try to get in touch with your son and also get my consultants involved in this. Okay? Thank you for speaking with me today.
Okay. Perfect, Dr. Ayula. Really, it's perfect one. Thank you, Dr. Ayula, Dr. Abdullah, for being very hard to understand and to accept. Let's hear the comment. Then, Dr. Ayula, please prepare a scenario for Dr. Abdullah, okay?
Okay.
So, what do you think? You're taking UK or Irish?
You said what?
UK. She's in UK.
So, in the end, you should declare was all about capacity. So, first, you check the understanding very good. You need to check you checked retaining of information, and also you checked the weighing risk and benefit of the patient, and you notice there is no communication. So in the end, you should say to the examiner, or no, you say to the patient as a way you are delivering this conclusion. So, Mr. Ahmad, we are sorry that we are going to connect you to a device, given that it looks like, given that your capacity is impaired because of this acute illness, and that's it. So, because clearly he has known the 4 criteria of the capacity. So, but you did it well. You checked all the 4 things. Just that last conclusion, you should say it. Yeah, that's it.
Yes, Dr. Abdullah. But I don't think he will be accept to be connected to the machine. He said, I cannot. I think he understand, but when he's mentioned, I don't want the mask. So it's
No,
difficult
but
to, yeah.
no,
Yeah.
there is no understanding. Like, it's just answering some small sentences. It doesn't
Yeah,
mean
so how
full
you will connect
understanding.
him? So how you will connect him if he's not understanding?
If there's
He will be more
impairment,
resistant.
but if there's
Yes or no?
impairment in the capacity,
You mean you will force
Doctor,
him? How you will
Doctor,
connect
Doctor,
something he's not
Doc-
understanding it? This is my
Dr.
point.
Basim, Dr.
Yes,
Basim, if
yes.
there is impairment in so yeah, you should say the legal issues. So what are so I understand there is autonomy of the patient,
Yeah,
but that's once the patient has the capacity. If there's impairment of the capacity, yes, we should speak maybe with the family members, next in kin, but
yeah.
the decision eventually, if there is no, the decision will be, uh, the decision will
Yes, I,
be,
I agree. I agree. You can put him until his oxygen,
just a sec.
his CO2 will be
Yeah.
fine. You mean that?
So
Practically, let's talk about the practical point of view. Yeah, you
yeah.
might restrain the patient and connect to BiPAP
No,
till
not
this.
restrain. We
Okay.
cannot restrain. I mean, you can start by any way of. No, so before how to do that, that's like a technical point of view. But I'm speaking legal point of view. Do we have the legal authority to do something that patient is not accepting in this situation? So because of the hypercapnia could be the something, or could the patient has background of cognitive impairment or anything. So there is capacity impairment here. And if capacity is impaired, so the patient is not the one who is deciding the best of interest of the patient. So there is something that is life-threatening here. And the best of interest of the patient is to connect him to the BiPAP. You agree with me?
Yeah. That's I said practically you could restrain because he will remove it by anyway.
Practically, I don't know. That's the
Yeah.
experience
Okay.
needed,
If
and
he's not
yeah.
understanding, if he's not accepting even to talk with him, do you think he will accept the mask over his face? I don't think. So I think yeah, practically you could do as either to give him something to
Yeah.
to relieve him
Hmm.
like something like antipsychotic halobridol for the if he's agitated, for example, for a
Yeah.
while. Then you can connect him, and sometimes if he need, you can restrain him temporarily. Why? Because once the CO2 is washed out, the consciousness will be much better. But in the
Well,
paces wise, okay. Sorry to interrupt
yeah,
you.
no problem.
Yeah, what the steps Dr. Ayula did, I think it's the best. Why? Even if he's not accepting, you can arrange a meeting with your consultant that I couldn't convince this patient, and the consultant will sit with him in on a meeting. I will arrange another appointment with him, and if he's still resistant after checking the capacity, he can sign the form, the DAMA form, and he can be discharged. But I cannot. Maybe there will be debate about discharge him. Why he's not having the capacity to sign this paper? Okay.
Yeah, exactly.
Yes. So this is maybe this is the point will be in debate.
And Dr. Basim, sorry for,
Yes.
but
Yeah.
like, sorry that, but like in, like I don't think we will be ever trying to strain a patient. Like we cannot do that. Uh,
You
like
can't
it's
restrain patients now.
You will not
no,
mention it. You will not mention it in the
yeah,
cases.
yeah,
I'm
yeah,
saying practically. You will not say I will restrain, and you cannot say to the patient I will restrain you. I'm
of
talking
course.
about practical experience. Such
Okay.
patient, you could restrain them until the CO2 will be fine. Then you can release restraint. Okay, so
Yeah.
it's okay only as a practical part, not as a basis. No one will say that. Please, I didn't say to
Yeah.
say this. Okay, no one to
Okay.
say I will restrain the
Okay.
patient.
Okay.
All you can say to the examiner, I will restrain. Or you will
No.
say to the patient himself, I will restrain. It's
Mm.
something against the welfare. Okay, no one to say that.
Mm.
I'm saying practically only. Okay.
Okay.
What I want to say, Dr. Ayula did perfect. Really, she
Yeah. Yeah.
tried to
That's perfect.
convince. Yeah, the seriousness of the condition. She tried to speak about, but she didn't mention if you go home, your life might be threatened if you didn't respond to our medication or our management plan. This is the only thing you missed, Dr. Ayula. But you said breathing failure, oxygen is low. All these things, yes, might happen. But what is the most serious one, Dr. Ayula? What do you think? Could could this
Yeah,
patient die
you can
at home?
die. Yeah.
Yeah, so you can say, tell him, it's one of the our thing we are afraid of. You might have breathing stop due to breathing failure, and it might threat your life. For that, we advise you to stay for a while to connect you to the machine. Then address the other concern. But he should understand, know what is the most serious thing you have to talk about.
Mm.
Okay?
Mm.
But in general, you can pass this station. It's clear
Yeah.
that you know how to communicate, how to convince, and at the end, you have to give him appointment with the consultant or the senior who can
Mhm.
sit with him and convince him in another way.
Yeah, and you finished it in a very nice way, actually. Like you checked with the team, with the seniors, and but I think speak slower. In a normal situation, you would check understanding every now and then. Uh, and in this station, it will be even more required.
Yeah. I think she asked many times, but I prefer to ask him earlier. Where are you now? Do you know where are you? Do you know what the
Uh,
time is now?
So that's the orientation. That's different.
Yeah.
So the patient can be oriented but not having capacity. So he can be oriented even if he is not having capacity. So that will be that's not required here.
So in this station now, just to check, what do we need to ask those short mini mental state question? Like, do you know where you
Yeah.
are?
No,
Do you know what
no,
we are
no.
doing for you?
No,
Dr.
no,
Like,
that's
Abdullah,
different. That's
why? Why
different.
not, Dr. Abdullah? Why not?
That because that is different from the capacity. The capacity is four criteria: is retain, understanding,
Okay.
uh, and
And if he doesn't know the time and place, do you think he can retain and
no,
understand?
no. But because, like, let's be clear, everything is so that's disorientation, which can be an acute delirium. That's the delirium.
Yes, CO2 narcosis can cause delirium.
Yeah, it can be, but it doesn't mean so if it is normal, that doesn't mean the patient is very okay in terms of capacity. So the capacity is like is not like every patient with delirium can be not in capacity, but not every patient having is having capacity
Will be
will be
disoriented.
delirium. Yeah.
Okay. I got your point, but it's okay. For me, I will ask one question at the beginning just to know if he is following and
Hmm.
oriented. And I will show
Okay.
the examiner that I'm checking even the orientation. It's one,
Okay.
it's part of the conscious level. Okay.
Okay.
Yeah. But in general, again, Dr. Ayula did great. Thank you, Dr. Abdullah, for the scenario. Dr. Ayula
Uh,
for the performance. Any comment, Dr. Abdullah, you want to add?
no, that's it.
Okay, Dr.
Thank
Ayula,
you.
did you prepare a scenario?
yes.
Okay, send it to the chat box. Now we will open the discussion. Anyone want to address or to add any comment?
Assalamu alaikum.
Alaikum salam, Dr. Ihtisham.
Yeah, I think that in a way
Yes.
it was pretty straightforward. So I think that the approach, I think that Dr. Ayola done very well actually.
Yeah.
So I think that it was a simple case in terms that you just need to assess the capacity. So you just need to follow those four things first of all, whether so first you need to communicate, then whether the patient is able to retain that information, weighing the risk and benefit, and then is he able to communicate the decision. So if all these four tick points are being tick box, so I think that after you tick those boxes, so I think that one thing is clear. Obviously, I'm not talking about this, but generally, if you have seen and done all these four steps, this means that you have assessed. So if you feel that someone not going as per the definition of the capacity. So this means that the patient lacks capacity, and then you will think about the best interest thing. But I think in this case, the main thing was to assess the capacity. I think that was the main task because everything else was related to that. The other thing is that if the patient has an acute, I mean, delirium, so most of the time they do lack capacity. So majority of the time they don't have capacity, and you cannot say that the patient has capacity and you also say that the patient is delirious. So it is better. I agree with you and Dr. Ayola that you can ask simple questions just to see whether the patient has been orientated, whether he is able to tell his date of birth, where he is at the moment. So there is no harm in asking these two or three questions. And then you, because I think I didn't, I mean, uh, I don't know whether Dr. Ayola has checked the understanding because you need to explain the severity, and the patient kept on saying that I want to go. That's fine, but before answering that question, I think that you could have just asked that, okay, whatever I have told you, just repeat me, just to. It's your right, obviously, it's your legal right that you can go if you want to, but I just want to know that what exactly is your understanding. So just to see whether whatever you are telling, whether the patient is able to understand that, retain that, and also to assess what exactly is the patient thought, that what risk he might be having if he is unable to follow. If he is able to understand, is able to retain, and is able to understand, weigh the risk and benefit, and still he feels that he don't want to stay in the hospital. Yes, so you will say that the patient has capacity and he has the right to make the decision. And obviously, in that case, the patient autonomy will take priority over anything else. But if you have doubt, obviously in that case you can go the other way around, and in that case you most likely will think about in terms of the patient best interest. You may need to involve the family members as well and the other team member just to make a collective decision. So I think that so most of the time, if the patient lacks capacity, so next point of contact is the next of kin, just to explain them as well, because then you are legally covered. So that's my comment on that.
Yes, thank you, Dr. Hasham. Do you know, Dr. Hasham, what the trick in this scenario? Offering a DAMA paper or form, because you are just saying to him, yes, you can go home and kill yourself. I think so. It's unsafe to offer this form in his situation. So what you can do, you can involve a family member and a consultant before letting him go home. And I don't think this patient can go home, so you can even detain him, right? To be
But my,
reassessed
yeah,
again.
my point is that if he
Yeah,
if he lacks capacity, you
yeah.
will not offer
So
the DAMA form,
exactly.
because
Yeah,
it's only if he has the capacity, only then he can sign that
exactly.
self-discharge form.
Yes.
And then
Yeah,
if he lacks capacity,
exactly.
in that case, he cannot go. You need to involve the next of kin, you need to
Yes.
involve the other team member, and then make a collective decision. So if he obviously, if he has capacity, then the things will be little bit easier. I mean,
Yeah,
if I
yeah.
have capacity and I want to, I understand the risk and everything, and I still want to go. So obviously, I have the legal right to go. But my point is that the DAMA paper will only be offered if the patient has
Yes, you're right.
capacity. If the patient lacks capacity, in that case, you will not give the option
The,
of signing,
is-
because if he lacks
yeah.
capacity, he says, okay, fine, give the paper to me, I'll sign, I'll go, and then that will be basically a problem legally for you as well, because he basically lacks capacity. So this is my point. Yes, if he has capacity, then that would be the next step, that you, after assessing the capacity, then you'll offer, okay, it's your right, and you can go and just sign these form. I remember that similar kind of a scenario after a paracetamol poisoning. A young girl came in with a paracetamol poisoning and was treated, and the next day she said that I want to go home. But obviously, in those cases, and that poisoning was basically a suicidal intent. So in those cases, you cannot allow the patient to go home. The patient, even in those cases, the patient has capacity and she understands the risk and still want to go. But in those cases, you are legally bound to have a mental health review before sending the patient home. So you can actually detain these patients who come up with a suicidal intention and have some kind of a ingestion of any kind of substance. So that's different. Even
Yes.
in those cases, the patient has capacity, but you cannot offer them to sign a DAMA and go home, because it's your
Yes.
legal obligation that you need to involve the mental health team, and then only then the patient, they can assess, and if they feel the patient is safe to go home, only then the patient can go. So this is my point.
Yes, thank you, Dr. Sham. I agree with this point. So it will be hazardous if you allow him go home, legally and medically as well. So the best way is to tell him, okay, we will arrange a meeting, and we can call also his next of kin to sit with him and to try to convince him. But never ever offer an DAM or ADAMA form to any patient who is lacking any capacity. Clear, Dr. Ayula, because I think in this scenario with the lack of capacity, it's unsafe to offer him the DAMA form. I don't know if they can bring such scenario in cases with a resistant patient, and till the end he's resistant and he's lacking of capacity. And the if any one of the candidate the mentioned the DAMA form, I don't know, you can fail him. I didn't hear about this feedback before that
Yeah, I
scenario
think
came
that
like this.
this is no, no, Dr. Basim, this is quite clear. This is a failure point. If
Yeah,
someone lacks capacity and you are offering him a DAMA form, so
yeah,
this means that
exactly.
you don't understand that what exactly is
Yes,
the legal
yeah,
issues you can face. So anyone lacks
yeah,
so in this scenario, I mean, just I can tell in this scenario, it was the first thing the candidate needed to do within the first couple of minutes was to assess capacity, and it wasn't that difficult. You could just ask, because you need to just tick those four boxes and then make a decision. If the patient lacks capacity, then you need to involve the next of kin, because there is no other option. You will not be legally covered if you just give a demo to the paper to sign and then just go home. Yes, if the patient has capacity, then you legally you cannot ask the patient to stay in the hospital, and you cannot go. So it is all the legal binding. The first thing, I think the important point was, in this scenario, just right away you need to assess the capacity. And if the patient lacks capacity, obviously then the things will be much more easier. Then you know the process, that you need to involve the next of kin, the other team member, the consultant, and then make a collective decision on based on the best interest of the patient.
Okay, let's
Yes.
say, Dr. Aida, last comment. In PACES, they will not bring patient with such morbidity or comorbidity, and he will be lacking capacity. You will try to convert him, but he is having the capacity. And eventually, you will offer the Damafol. But in the paracetamol toxicity, as Dr. Hisham mentioned, patient had trial, which is a the very serious attempt of suicide. Never ever let the patient leave, even if she ask you repeatedly, "Doctor, I am fine. I want to go home." You have to revise with the patient, of course, the capacity, and refer her or him to the mental health team to assess the capacity within 72 hours, as you know, and everyone know.
Yeah.
Okay, you know that. Okay, thank you, Dr. Ayula. Let's read the comment. The scenario, Dr. Abdullah. Your
Yeah.
role: you are the doctor in the medical in the ward. The task to speak. The patient daughter has requested to see you, Mrs. Magda, 80 years old. The relative, Bushra, 45 years, the daughter. Scenario: Mrs. Magda Ali was admitted yesterday with a pleural effusion of unknown cause. Your consultant requested ultrasound guided diagnostic pleural aspiration to investigate the cause. A nurse who was present during the procedure has informed you that the consultant didn't fully explain the procedure or to obtain a written consent beforehand. Following a procedure, Mrs. Magda appeared distressed and in pain and required analgesia. Her daughter, Mrs. Bushra, is now upset about what happened and has asked to speak to a doctor. So I'll give you 2 minutes, then we'll start. The other comment quickly, I will try to read. Okay, Dr. Amal or Amil should be able to outweigh the risk and benefit. Exactly, this is one of the capacity point. Dr. Ihda, could you please speak about headlines should be discussed first? Scenario. I cannot understand this part, Dr. Ihda. What you mean about headlines of what?
As a summary for first scenario discussed now.
Yes, okay. So it was a scenario about patient with the respiratory failure type 2, and he was refusing the BiPAP. Your task is to check the capacity of the patient and to convince him to stay and to connect him to the BiPAP. He is having CO2 narcosis. Okay, so the scenario went as the patient is little bit confused or drowsy because of the CO2, and all the scenario was resistant even to talk or to stay at hospital or to be connected. We discussed about the points of capacity as this patient in CO2 narcosis. He cannot retain the information, he cannot decide, and we cannot judge him on this part. And eventually, he cannot go home because of the CO2 narcosis. So the best interest of his condition, we will let the patient stay. We can call the family member, and we can arrange a meeting with the consultant to convince him. During this time, you might connect him to the BiPAP temporary in order to remove or to wash out his CO2, which is affecting his conscious level. Okay, but in the exam scenario, no need to talk about forcing or put the patient on the machine without his approval. So you have to call a family member to stay with him, and during this time you can connect him if the family or the next of kin can convince him for a while to be connected to this machine. But don't offer a demo form as long as the patient lost the capacity. He cannot sign a form on his responsibility during the time he's lacking of the capacity. Okay, this is the summary of the old scenario and the discussion we have discussed after the performance of the candidate. You got it, Dr. Ihda? Of course,
Thanks,
in
Doctor.
between, yeah, it's most welcome. Of course, in between, you have to check the capacity, asking, understanding the points you are asking, and talking to the patient. At the end, you can ask him to recap. And I don't think he has the capacity to repeat all the information. That's why you postpone the decision for connection until he can sit with the consultant or his next of kin can come. But again, as we resulted from our discussion, you cannot offer dama form to a patient who's lacking capacity. It means that you are killing him by indirect way. Anyone has comment before moving to? Okay, Dr. Hisham wrote for you also some point. Explain, check, understanding, retaining information, weigh risk, benefit, communicate decision. This is the parts of capacity or the items. Dr. Hisham, and killing yourself in the exam. Of course, you will fail a station if you mention dama form to patient without capacity or lacking capacity. I think it's a tricky scenario, but I didn't hear about such scenario with lack capacity.
No, there is ICD insertion, and the patient was not having capacity actually.
Oh my God.
Yes.
Okay.
I think that, yeah, I think that in the exam we do find scenarios about best interest, obviously, because a lot of time for other reasons, obviously they might be doing quite poorly and they might be quite sick, and in the process they might lose capacity. And I have seen scenarios like someone having otherwise young and having a roadside accident with a severe subarachnoid or intracerebral hemorrhage and unconscious and all these things. So in those cases,
Yeah,
obviously the
yeah.
patient. So best interest scenarios are not uncommon. So they can come in the exam.
Yeah, it's coming, but not as common as the
Yeah.
medical error and the other
Yeah,
scenarios.
yeah. You're
So the
right.
trick, again, the trick not offer the DAMA form. You cannot ask a patient to sign a form where the same time he is lacking capacity. How he will sign it?
Yeah,
Yes, exactly. Okay.
absolutely. Yeah.
Thank you, Dr. Abdullah and Dr. Hisham. It's a nice discussion as usual. Let's start, Dr. Ayula. Ready? Dr. Abdullah, ready?
Yes, I am ready.
Okay, here you go.
Hello, I'm Dr. Abdullah. I'm one of the medical doctors in the ward. Is this Mrs. Bushra, daughter of Mrs. Magda, 80 years old?
Yes, doctor.
Mrs. Bushra, I hope you are not waiting too long for me.
Well, not too long enough to be hungry, doctor. Yeah, no.
I am here to I have been called that you need to discuss with me. So I am here. Could you tell me about your mother condition, what you have been told so far about her, and what is mainly about like you need me to discuss with me first?
Yes, doctor. My brother came in yesterday. She's been having difficulty with some shortness of breath. And I returned this morning to visit her, and I found a tube on her chest. I tried to speak with her what has happened in my absence, but she was unable to reproduce this to me. Honestly, doctor, I'm not quite sure what has happened. Why the tube? Nobody told us about this. And the sad part is my mom is currently in pain. She's feeling uncomfortable, and I'm not happy seeing her in such situation. It makes me feel terrible.
Really
Doctor,
sorry. I'm really sorry.
Honestly, I don't know why all this have happened. At least someone should have spoken to us about this.
I'm really sorry first for seeing your mother in pain and all this. I need you first to know that we are a medical team. Everything we do is to help her as much as we can. And I understand the frustration. So, but just let me explain first why this tube has been in. The consultant yesterday decided that this tube is because let me draw for you actually. So we have here the lungs, which are almost like a bag, filled with air. But when there is some leaking of this air, there is a space around the lungs that can be filled with air and or any fluid can form around that space. And that will prevent the lungs from expanding and make shortness of breath. In that case, in your mother, there is a fluid around that space. And I'm sorry, not getting into much details. I shouldn't get into too much details. But there is unknown source or unknown cause. And the consultant, as a way to discover why this is happening, so we need to take that sample or take that to know the reason so that we are able to help it and treat it. And I am really sorry if nobody informed you about this point, actually. And so it's actually, first of all, so stop me at any point if you don't feel me speaking clearly or you have any questions. Interrupt me at any moment.
Yes, doctor. Yes, thank you for that opportunity. I quite appreciate that you are doing everything you can, to help my mother. But it's just so frustrating when you are not carried along with the treatment. I mean, with what has been planned. This is a life. At least she has the right, and as family, we have the right to know what's going on, why, and you're suffering. If you're having pain, you should know why you are having the pain. Now she's she's distressed and she's having pain. We don't even understand why this is happening. We don't understand what is next is being planned for her. Doctor, this is just my concern. I really appreciate that you are doing the best to help her. But this is just not acceptable.
Okay. So and I'm so for the pain, I will make sure there is adequate painkillers given for her, and also I will we will reassess and see if this pain is related for if there's anything apart from that procedure happening, or is it just the procedure made her in pain. So, have you understood why have you understood the way of this tube has been inserted, and where is it inserted in, and how is the procedure and all that?
Well, I think you just said something to me about that right now, which I think, yeah.
Okay, and yeah. So, Mrs. Bushra, my apologies actually for this procedure. If that happened, ideally it should be taken with consent. And I'm sorry that nobody contacted you as a family, or and actually there was no consent actually taken from your mother for that procedure.
Oh my God.
But I've been informed about that from one of the staff, and I need to make sure about that point. I'm not. We need to understand why that happened and what are the surrounding situation around that time. So in some situations, if there is urgency or emergency to save the life or something like that, or if there is a delay, any delay that would harm. So in that, I'm not sure again if that's the case, but in the same time, I am sorry and my apologies, and you can actually be frustrated, and I am really sorry for that. If no consent has happened, or if you're not explained, or your mother, about this, and what are the complications and all these stuff.
Okay, doctor, I'm just wondering, because my mom was not in pain when she came in. It was just breathing issues. Do you think this procedure has harmed her?
I don't know. We will need to run more investigations, actually. We don't know. I don't have something yet solid, if you understand me. So we need to do more tests. We need to run X-ray again, imaging, to
2
see.
minutes left.
In some cases, there is it can lead to complication of air surrounding in that space instead of the fluid, or it can lead to bleeding from that needle. And I'm sorry to inform you that, but I should tell you that it could be the case. And I will make sure to run X-ray, and we will need to investigate that.
Okay, so how do we go moving from here? Which way do we go moving from here?
Sorry?
What is the next plan for her? How do we go from here? Because
First, let me ask you a simple question. Does your mother have any wishes written, or any advanced? Did she have any decisions, advanced decisions made legally, that we should be aware of?
Hey, doctor, I don't understand. Why are you asking this?
Oh.
Is she dying?
No. I'm just in. We asked this question. No, she's in pain. She's fine. But okay. I will run a meeting with my consultant and the team, and we are happy to arrange a meeting with you as a family to discuss in a better way, and clarify all the vague issues again.
Okay, doctor. Okay, doctor.
Okay. Do you have any concern else?
No, I just want my mom to be fine, honestly.
Of course. I will make sure that she's fine, and I will update you again. Is that all right?
That's fine, doctor. Thank you.
Yeah. And I think you should, if you want to complain about this consent not being happening, not done, I will guide you to an office which is does not belong to the hospital. It's independent. It's called Patient Advisory Liaison Services.
No, I don't want to go through that path. All I want is my mom to be good, to be all right. Thank you.
Okay. Yes, time is up, Dr. Abdullah. If you want to ask something else, what do you
I
think?
will ask about if she how is her situation at home?
Yeah, exactly. Yes.
How is her? Yeah.
Who's living with her? Who's dependent
Who's
on
living
her?
with her? Who's dependent?
Yeah,
I don't think it's wise to ask about smoking here, because that's the relative. Yeah.
Okay. Yeah. No, not wise. Okay. Time is up already, so we can hear the comment from Dr. Ayola. Then I will comment. Well done, Dr. Abdullah. Yes.
All right. Well done. It's quite a good presentation, Dr. Abdullah. Well done. A good you handled the station well. Of course, just one or two things I think we should discuss about this case. This case is basically a medical negligence, right? Case, and is a negligence, right?
Oh yeah, okay, negligence, okay.
Negligence, yes. And I like the way you went about it, initially trying to explain the procedure, because of course, the first thing you need to do is to let the patient understand the procedure and why it has been done for the relative for and apologize profusely about the procedure. And again, emphasize on the fact that normally when we want to do procedure like this, it's always good to say the normal thing we would have done. Normally, when we do like this, we discuss the risks and benefits with the patient, and we give them the opportunity to take their own decision whether they want to go ahead with this or not. But unfortunately, this was not done in the case of your mother. We apologize. This is something that shouldn't have happened in the first instance. But however, like you said, there are situations whereby we take decision based on the best interest of the patient. I'm not quite sure if that is the case, which you did, which you said very well, if that is the case. But we will want to investigate this further and get exactly to the root of this. I think in this case, in this thing, and in this situation, we need to put in an incident report as well. In this case, though it's not an error, but you need to put in an incident report because something has happened, something significant has happened. So you need to put in an incident report in this case as well. Then reassure the patient over and over again that we hope that this will not repeat itself, and we will ensure that we discuss all treatment plan as we go ahead in the management of your mother. You also assure
Sorry,
the
can you
patient that
repeat
she's
the last sentence? It
you will
wasn't
you will reassure that as we
okay.
go in the treatment management, we will explain every step to them clearly,
Okay.
to to our mom and the relative if needed clearly. And
Yeah.
then you also say that we'll give her a close monitoring because she has just had the tube inserted. We'll give close monitoring, and in terms of her vitals, we'll also give her some painkillers just to rate the situation at time. I don't think you need to offer pause to this patient. And I don't feel confident as well about raising which advanced directive in these patients, because this can trigger the relative. Fine, if it's an 80-year-old woman having this kind of thing, well, it's a good thing to think about it because of course she's nearing the 30s. But this, I don't think we should raise it at this point because this patient is a patient that can easily. She's just trying to keep calm. She's upset. Saying such thing can trigger and say, so my mother is dying, and you are still you are not explaining things to us. Why? She can pick that again as something that is not too palatable for her at that time. So I don't think you need to raise it. But if you think it's important, you can just say something like, there are other things I will discuss at a later time. But at this point, we want to focus on ensuring that your mother is stable and just looking after her and ensure that everything we need are in place for her this time. Just to let you know that there are other things we need to discuss, but not raising it at this point. And like I said, we don't need to offer pause at this time. This relative just need the reassurance that you can trust us with your mother. Important to say, explain the procedure, reassure the patient that the doctor that we would be monitoring the mother and things that we would do to ensure that the mother is safe and our health and right is not jeopardized again. And then put all those things that we used to do, risk assessment, then reports for her and reassure and address concern with this patient. Thank you very much.
Very good. Thank you. Yeah.
Okay, thank you, Dr. Ayuna. Yes, I agree with both comments. So you did perfect, Dr. Abdullah, apart from these 2 points. Advanced directive, never ever to talk about it in acute setting. Any patient admitted with acute setting, which is not expected, no need to explain or to talk about advanced directive. Why? As you say, the reaction will be in the same way of Dr. Ayula. What do you mean? She will die? And by this way, the examiner will notice that you ask, and you not only that, you even harm the emotions of the relative, right? So it's a negative feedback here. The other one is the offer for a PALS office or complain it by any way. No need to raise it unless the surrogate asks you, doctor, I want to complain, I am not convinced. Here you can tell her, yes, I will guide you to the PALS office. The other comment about admitting the mistake. You already apologized, but I think at the minute number 5, which is very late. Whenever you feel there is error or mistake, admit the mistake from the start. Once she talk about no consent, after she speak about her background, immediately apologize on this and tell her this is not our habit. We used to get a consent before doing such procedure or any procedure. And maybe something went wrong and it's not intentional, I assume. And we used to get a consent, as I said. And not only that, we inform our the supervisor, consultant, root cause analysis, the all steps of error to investigate and to know where the defect exactly, what happened exactly to miss this consent. Supposed to be a consent form there. Then the reassurance, painkiller. Yes, she is in pain. I'm so sorry for her suffering now. We will offer her appropriate painkiller to be sure that she is calm and comfortable. Why she is distressed? Yes, you can answer this part, as you mentioned. We don't know. Sometimes there is complication might happen. And even here, you can assume that you explain the complication to the mother. And as every procedure, there is possible complication. One of them, the pain itself. She's in pain. You didn't mention the pain as a complication when she asks you, doctor, why she's distressed. So you can say maybe the pain itself can cause the distress, right? Any patient in distress or in pain, he might be distressed, and he will be tachycardic, tachypnic, because of the pain, sympathetic activity. But you explain local complication like pneumothorax, and you mean also, I think, blood, hemothorax, or something else.
Yeah,
Yeah.
bleeding.
So, yeah, bleeding. So it's okay to mention the local cause, but there is solid
More
reason.
common.
Yes, not only common, and it's also mentioned in the scenario, patient in pain, and this pain can lead to this distress, right? So you can tell her, yeah, I think because of the pain, that's why we are going to call the pain doctor and to give her the potent and appropriate painkiller and to be sure that she's not in pain. Okay. Otherwise, yeah, the communication went good.
About the
Yes.
sorry, also the meeting of the root.
Yes, root cause analysis. Yes.
Okay.
Yes, everything will be the report because there is something missing here in the scenario. And it's written clearly in the scenario, the consent not obtained. And as you know, every procedure, you should obtain a consent form, right? By the way, it's not from the daughter, from the mother. The daughter could be informed about the procedure, but the son, the person who signed the consent will be the person who will be undergoing the procedure, as you know. Clear?
Yeah, you mean the mother.
Yeah, exactly, the mother. But you can inform the daughter about the procedure by phone if she's not attending.
Yes.
Okay. Thank you,
Thank
Dr.
you.
Abdullah. You have any question?
No, thank you. That's very good.
Okay. Anyone want to comment or add question or comment about this scenario or previous scenario? Please, whenever you find a mistake in a scenario, admit the mistake from the start. Don't wait. Don't waste the time talking about something else. You have to admit the mistakes. Why? Because you have another steps you will do after admitting the mistake. What are the things? The apology, of course, the beginning after the admission, and informing the supervisor or according to the level of the mistake. Either supervisor, if the nurse is shared in this mistake, or the consultant, or both of them, because all mistakes or was at all levels, and we are, as you know, teamwork. So the mistake is a mistake of the team, not of a certain person. So the apologize or apology, followed by the incident report and root cause analysis. Even we have meeting monthly discussing such points or such mistakes in order to improve the quality of services and not to have this mistake to your mother or to any patient else. This is our aim of reporting a mistake. Okay. I noticed nowadays every scenario or every diet, most of the diets and carousel, they have a medical error scenario and another scenario like palliative, like counseling, like complication, procedure. But the medical error is sharing all the diet scenarios. I'm not sure 100%, but I can see in the recalls scenarios, the medical error is very common to come. So please be aware about the steps of the error. Not only that, try to practice it at the most common scenario coming. If you want to practice scenario with your partner before the exam, do the medical error scenario. Okay. Anyone want to comment?
Yeah, I think that I just wanted to ask Dr. Abdullah that when he read the scenario, obviously you know that in the exam you will have 5 minutes before you go in. So after reading the scenario and when you are, suppose you are in the exam and you are outside, so what are the things, I mean, because you need to have an action plan that how you are going to approach this scenario. So I just wanted to ask you after reading this scenario and before starting, so what was your action plan that which way you are going to, because you need to be very clear before going in that which way you are going to approach. So what exactly was your thought process that how you are going to approach this scenario when you'll go in?
So you
And then
should
I will
mention,
come.
you should first know who are you exactly, so the medical doctor in the ward, and then who are you speaking with. So Mrs. Bushra, the daughter of the Mrs. Magda, 80 years, and you have an introduction, and you should understand what the patient was told, so what the relative was told
Yeah,
so far.
sorry. I think that no, this is the format. I fully agree. But my point is that after reading the scenario, so you know that there are basically 4 or 5 types of scenarios in the exam. Either you get a scenario about the consent, either you get a scenario about explaining the disease, either you are so
Sorry, Dr.
in
Hisham.
which
Yeah,
in
I will try to clarify. Yes, he want to what the task you went
yes,
through.
yes. So
What's
what exactly you thought was the task in this case?
exactly?
I mean, before going in those 5 minutes when you were reading and you are making a plan that what you are going to do inside. So what exactly medical? Very good. So you are talking about so medical error. This was a medical error, obviously. Now you have a very clear plan whenever you are countering a medical error. So the first thing is obviously you know that this is something which has happened. So don't try to defend that. Obviously you didn't do that. I'm just saying. So it's kind of first of all when you go and you start your discussion with the patient and the patient or the family member says that okay this has happened and you know that this is a medical error. Someone said medical negligence. So medical negligence cases they generally don't come in the exam because this is not something which is intentionally done to cause harm to the patient. So this comes under the medical error. So it is a medical error. So first of all, when the patient or the family member, whoever you are speaking to, when they say this has happened or whatever, so just accept that yes, this is something which has gone wrong, and I apologize. I am very sorry for that. So your I mean, discussion should start with acceptance and acknowledgement of the problem that something wrong has happened. So just accept that, apologize that right away. So this should be within your first 1 or 2 sentences after listening to the patient or the family member. And then listen, okay, now just explain that the current symptom obviously because she was concerned about the pain and the distress. So the pain obviously you know that I'm sorry that your mother have not been, or you might, obviously it's mother, because uh, I assume that there is nothing to doubt the capacity. So you can say that I understand that your mother have not been properly explained about the procedure. So this procedure can lead to pain, obviously, because we are putting a needle in, although we do numb the area, but sometimes this can happen. So most likely that's the reason why your mother is having. Just offer, if your mother want any painkiller, so I can give those pain medication as well, just to make her comfortable. So just explain and reassure, because this is a kind of a, you don't need to show counter aggression, or just, I mean, try to negate whatever the patient or the family. Just accept that, because you know that the mistake has happened. So the best is just to accept that, acknowledge that, apologize that, and give the patient or the family member the plan of action. So what will be your plan of action in the given circumstances? Tell them that what you are going to do. So you said about the incident report, that this is something you are going to put an incident report, that because I know that this is something which happened to your mother, which should not have happened, but it is important that we do make an incident report. And the issue and the benefit of these incident report, obviously, whatever has happened to your mother, we cannot reverse that. But it is not about your mother only. Obviously, we need to reflect on our practice, so that in future no such incidents happen with anyone else. So you need to explain that it is basically a process of the good clinical practice. So that's, you need to do an incident report. And then you can even, I mean, obviously at the end you can also ask that if the patient or the family member wants the consultant to come over and have a meeting, because the task is with you. So don't say that right away, okay, the consultant have not taken the consent, and I will call the consultant, because it is your exam, not consultant's exam. So you need to first try to convince, and at the end, if you still feel that the patient or the family member is not convinced, then even you can ask them, if you want, I can ask the consultant to come over and we can have another meeting and he can explain. And if you want anything to discuss with the consultant, I mean, just to show empathy in that case, just to tell the patient that how you can further support the family and things like that. So I think this is how it should be. So there should be a clear plan in that. I agree that someone already mentioned you should not offer the patient advisory and liaison service yourself. So never ever do that in the exam, that if you want to do a complaint, so never show the patient or the family member. Only if they ask, no, I want to complain. And sometime in the exam, you might find a scenario in which they will say, no, tell me the name of the doctor. So just don't put anyone into that position that, okay, it was Dr. Etisham, so you can put his name, because it is a teamwork. So never ever say that, okay, because a lot of time they will ask you about the name of the person who has, and this is something which we practically experience as well. So never give the name, that tell them that this is the service. You can just go if they ask, and you can just complain. It is a teamwork, so you can put a complaint, whatever the incident has happened, and they will investigate and they will update you about that. So I think that's how it should be. And never obviously, one thing, I don't know why you went into advanced directive, because there was
Oh,
absolutely no need to go into advanced directive, because the
yes.
directive in this case. Yeah, that's my thought on that.
Thank you very much. Thank you.
Okay, thank you, Dr. Hisham. In details, he tried to comment about the medical errors, how to do, and the action. Yes, in medical part of you, if in any mistake, you have to talk about medical action. Here, no medical action, because the patient, the consent already not secured, so you can say we will secure a consent, but the medical action might be here the painkiller because of the pain after the procedure. Okay, let's go to the comments in the chat box quickly. The last part of the session. Can I guide? Yes, we shouldn't offer complaint exactly. Dr. Hida mentioned. Yes, I agree. This scenario discussed Dr. Ahmad is the medical error. Exactly. Cannot guide patient to complain? Yes, absolutely right. Medical negligence case usually don't come in exam. It's medical error, whatever negligence or mistake or missing. At the end, it's called medical error. So you have to apologize and do steps of medical error. Here, Dr. Hisham wrote, accept acknowledge or admit, acknowledge, apologize, action. 4A's, action, insert report, pulse, only if the patient or family asks. Mark for welfare will be deducted. The plan, medical and legal plan. Yes, we should discuss, Dr. Amal mentioned. If the patient is competent and the relative said, I need to complain, how I should reply? Okay, we said, Dr. Hida mentioned, we said to him, you should sit with the patient and discuss this issue about complaint. Yes, exactly. In UK, not in like in our Gulf here, anyone can complain. So the patient himself should be agreed about the complaint. So you can tell to the relative, you can sit with your mother, with your father, and discuss with him regarding this complaint, and we are ready to guide you to the office of the complaint, which is called PALS office, Patient Advice Liaison Services. Okay, thank you for the comments in the chat box. Anyone want to add any comment before ending the session? Dr.
And
Ahmed?
Dr.
Yes.
Basim, regarding yesterday, because I was not feeling well, but I've listened to the discussion which was going
Okay.
on. So there was first case, I think, which was mainly in both of the case, I think they were GI
Yeah.
bleed, and
GI
the first
bleeding.
one,
Yes.
I mean, I was regarding. I think everything else was fine regarding the first case. I don't know whether Dr. Abdullah or Dr. Muhammad. I don't know who did it, but they mentioned the first diagnosis in an melena patient as colorectal cancer, if I'm not wrong. The first differential he gave that and explained to the patient, I think that most likely it is a colorectal cancer, and I'm sorry to tell you. And then he started. I, obviously I can. I need to take your input on that. Wouldn't it be better if you can explain into the patient and also for your examiner as well, just to say that I think that you have been bleeding from your upper gut to explain the patient, and we need to investigate it further. There could be potential reasons for that, and then explain those two, three things which you think could potentially be, rather than saying straight away that I think that you have colorectal cancer and then we'll investigate. So I feel that it would have been more appropriate to say that you have a bleeding from your upper gut and then tell the possibilities and then work up on that, rather than going directly and say that you have colorectal cancer. What's your, and colorectal cancer generally, it causes more bleeding rather than melena. So that's what I was thinking yesterday.
Yes, but the case was about HHT, the first scenario. The second scenario was chronic liver disease.
Yeah,
Maybe.
I know HHT, but that patient presented with melena. The patient presented with
Yeah, so
melena,
melina
and
because of something different, not cancer. It was HHT. There is a possibility to have a change in your blood channel or dilatation or widening of your blood channel in the gut. That's why it might easily bleed. I think this is the explanation of HHT.
yeah,
And its
yeah.
condition runs in family. Yes, go ahead.
Yes, I think that's only if you are able to pick that HHT. I'm just saying that if you are unable to pick, then treat it as a case of upper GA bleed and then explain the patient the possible causes. Obviously, it was a little bit
Okay.
odd to having the first episode of any kind of a bleeding in HHT without any family history at the age of 80 years. So it was relatively, kind of an odd age group to present for the first time as a bleed, because generally it is something which we mostly see in young patients and with a family history. But my point is that if you are unable to pick HHT, so wouldn't it be better to take
Yeah,
it as
yes.
an
Just
upper
to
GA
explain the
bleed?
melina, exactly. Yes.
Yes, upper GA bleed, and then explain it accordingly. The
Yes.
investigation would still be pretty much the same. But my point is that I think that the first diagnosis and explain to the patient that you have colorectal cancer, which I feel that a little bit not appropriate. That's what I
No,
feel.
no,
I
no. We
don't.
discussed this. Yes, it was wrong differential because the candidate couldn't pick up the HHT. So that's why he mentioned the cancer colon, but it's not the correct diagnosis. Anyway, to answer the concern wrongly, better not better than skipping or missing the concern at itself.
Yeah, yeah,
So if you mention it, cancer colon, okay, one of the possibility, but it's not the top differential. You can say it. If you couldn't pick up any diagnosis, as Dr. Hisham said, you can explain the symptom. You have melena because some of your gut bleeding internally, and this blood being dark because of the breakdown of the blood cells inside. That's it. For
Yeah.
what the reason, you can say there is some possibility in our mind. We will run blood tests, some scan, and we will let you know what is the possible diagnosis. I'm talking
Yeah.
about something you are not sure about it, so you can just give it as a vague, and the
Yeah.
concern marks you can gain it properly.
Yeah.
Then, till you go to the examiner, you can think what could be the reason while you are collecting your thoughts. Patient having family history could be something familiar. There is cancer family, so family history of cancer it could be so you can collect your thoughts while presenting the case. Okay,
Yeah, I
this is
agree.
yeah,
Yeah. And the other thing regarding the second case, I think that
yeah,
was about the decompensated liver disease.
exactly, yes,
With
yes,
I think that for exam point of view, if you come across a case of liver disease, so there are three things which you need to do basically, and that's what that the most of the examiners, the key is according to that. The first thing is that you pick up that the patient have a chronic liver disease or decompensated. Then the next thing you need to look into your history and examination is to find out the cause of that.
the
And
underlying
the
cause, yes, yeah,
yeah, so basically we say it is the three C. So first of all, cirrhosis. Then the second thing is to look for the second C, which is the cause. And the third thing is to look for the other C, which is the complication. So any one, because no one is going to, I mean, say that, okay, they will give you some marks but not the full marks. If you just say it is a chronic liver or decompensated, they want to know that what could be the possible cause in this
exactly,
particular patient, because that patient was not a smoker, not a very
alcoholic, yeah,
yeah, alcoholic. So
yes,
the most common is obviously this metabolic dysfunction associated liver disease. And but my point is that if you come across a case of decompensated liver disease, so you need to make sure that you cover these three C's, because the
yes.
questions will be based on these three C's.
Yes, agree for this. We discussed these points yesterday, but you have to roll out also, as I remind, to roll out the infectious cause because it's top preferential in elderly people. Nowadays, it's not that much common, but previously, because the patient I think was elderly, or I think he was 50s or maybe 50, 53, I think. Yeah. But anyway, during taking history, you have to roll out the infectious cause, hepatitis B or C could be the reason, and you have to ask about them, not only alcoholic and non-alcoholic. Okay, anything else, Dr. Hisham? Thank you for the
No,
comments.
thank you very much. Thank you.
Okay, thank you too. Anyone want to add any comment? Yeah, Dr. Ahad asked about the scenarios. So I made specifically the Facebook group to share the scenario, the session itself, and any photos will be shared during the session. It will be there also in the Facebook group in the comments, because I couldn't share it in the video in the YouTube session. I cannot share the photo or the picture. So I make the scenario as photo or screenshot, and I share it under every session in the Facebook post. So you can find the session itself, and you can find the photos of the scenario or photos for the patient picture, or anything will be shared during the discussion. And feel free to comment there. You can have a discussion about the scenario and as a written form. Okay, I shared it already, the Facebook group. I made it particularly for this reason, so everyone can see the scenarios and also can share any comment in the post down. Okay, thank you, Doctor. Thank you, Dr. Ayula, Dr. Abdullah, and thank you, Dr. Ihtisham, for the comment, and everyone attending today, Dr. Ihda. I hope I didn't miss any of you. Have a nice weekend. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Walaikum. Thank you.
Thank you.